everyone. A 35-year-old South Asian male presented to the ophthalmology emergency with chief complaints of pain and diminution of vision in the left eye since 4 hours. There was no history of similar illness in the past, no history of any ocular trauma, surgery, redness, pain, congestion, no previous history. There's only one history, that patient is an occasional cigarette smoker since past 10 years. So on examination, the right eye examination was mostly with the normal limits. The BCVA was 6 by 6. In the left eye, the vision was 3 by 60, which was not improving on pinhole. There was mild sluggish reaction of the pupil with mid-dilated pupil, and there was mild congestion of the conjunctiva, and grade 1 to 2 corneal edema was present. As you can see in this diagram, right eye is VH grade 4, left eye is VH grade 1 with grade 1 to 2 corneal edema. And on fundus examination, you can see in the right eye there is mild hypertensive retinopathy. In the left eye there is, in both the eyes there is severe hypertensive retinopathy, which is characterized by disc edema, arteriolar attenuation, AV cross changes. This feature doesn't have, this image doesn't have typical features of malignant hypertension such as macular star or hemorrhages or soft X-rays, but since there was disc edema, so we characterized it as severe hypertensive retinopathy. So, in the peripheral examination in the nasal periphery, there was this lesion which was query suprachoroidal hemorrhage. And after all these findings, we checked the BP of the patient, and it turned out to be 230 by 130 millimeters of mercury. Pulse rate was 89 per minute, and the rest general examination was within normal limits. So provisional diagnosis we made, both eyes severe hypertensive retinopathy according to Wong and Mitchell classification, with left eye acute angle closure crisis post query suprachoroidal hemorrhage with hypertensive emergency. Now since the BP was so raised, we started the patient on management right away. We referred him to medicine emergency for blood pressure control. Tablet acetazolamide and glycerol was started according to body weight after clearance from the Department of Medicine. We did not start mannitol because of high BP, and topical anti-glaucoma medications were also given. Patient was investigated for end organ failure associated with hypertensive emergency. So after BP stabilization, we did investigations on ultrasound B scan. You can see in the right eye there is normal retinochoroidal thickness. In the left eye, the retinochoroidal thickness is increased, and there is this raised localized anterior lesion with no after movements suggestive of suprachoroidal hemorrhage. We did UBM. In the right eye, you can see deep anterior chamber. In the left eye, you can see shallow anterior chamber and anteriorly pushed lens iris diaphragm. We did OCT RNFL, in which you can see increased RNFL thickness, and there is swelling of the optic nerve head. For systemic evaluation, creatinine of the patient is increased, which suggests kidney compromise. SGOT, SGPT are increased, which suggests liver compromise. And this is 2D echography, echocardiography. Ejection fraction is decreased. There is mitral regurgitation. There is concentric LVH, which suggests cardiac compromise. MRI brain was done, and there was this periventricular infarct, which was picked up. But despite all these features, the patient did not have any systemic complaints. So the final diagnosis is both eyes severe hypertensive retinopathy with left eye acute angle closure crisis with now confirmed suprachoroidal hemorrhage with hypertensive emergency and confirmed end organ damage. There was loss of follow-up because the patient kind of got scared for his life. So on follow-up, there is this brownish lesion which suggests previous suprachoroidal hemorrhage. The disc edema has resolved and there are no glaucomatous changes. The IOP is 14 mm of mercury on no anti-glaucoma. There was a similar case reported in 2010 in Iran, in which the features were similar, but there was no end organ damage. And in 2018 also, there was a similar case presented.
You have, I think, already crossed the time. You must stick to the time because marks are cut for overshooting the time, okay? Can you just summarize?
Yes, sir. So the take-home message is that hypertensive patients can present with just ophthalmic manifestations and no systemic symptoms. And the most important thing is multidisciplinary approach in such cases to prevent the patients from mortality and morbidity due to end organ damage. Thank you.
Thank you very much. In fact, it's a very good case because we must pay attention to systemic things along with just looking at the eye as a single organ. So thank you very much for bringing that.